Professor Simon Hart is Professor in Respiratory Medicine at Hull York Medical School and a consultant at Hull University Teaching Hospital. He has been a friend of Sarcoidosis UK for many years and is also a member of our clinical board. For this presentation, though, we've asked him to go right back to basics, as we know from the questions we get asked daily that there is still a real lack of information about this disease. So, Simon, what is sarcoidosis?
Thank you, Graham. Thank you to Sarcoidosis UK. Thank you for inviting me. Good morning, everyone. I will do my best to try to explain what we know about what is sarcoidosis. Hopefully you should be able to see my slide screen there, and we'll kick off with a simple case study, which is a nice way of introducing things. So a gentleman is referred to my outpatient clinic because he is breathless and has a cough. And this has been going on for a few months, and his GP has tried some antibiotics and they haven't worked. And he's also complaining of aches and pains in his muscles and joints. And he has a chest x-ray, which is a useful initial test in someone with new respiratory symptoms. And the chest x-ray shows enlargement of the lymph glands, changes in the lungs. He goes on to have a CT scan of the chest, which shows these changes in more detail. And then he goes on to have a biopsy of one of these abnormal lung areas. So a biopsy is taken and examined under the microscope, and it shows a characteristic collection of the patient's own immune cells forming what's called a granuloma. A couple of hairs' width in size, and it's the collection and aggregates of these individual granulomas that form the visible lesions of sarcoidosis, which in this case we can see on the X-ray and the scan. Importantly, the pathologist looks in the granuloma for any evidence of infection and finds none, and we'll come back to why that's important later on. So, and we'll come back to this case later as well. But our patient here has problems mainly in his lungs and his lymph glands. And these are the commonest areas of the body that are affected by sarcoidosis, but many different other parts of the body can be affected, but everybody is different. The eyes and skin are also quite commonly affected, but sometimes the internal organs too. But the key to understanding sarcoidosis is that granuloma that can be seen under the microscope. Here's a different biopsy, this time from a lymph node, a lymph gland, and this is in fact the commonest site for biopsy in sarcoidosis nowadays. In the middle and the top of this slide, you've got lots of little dark blue dots, and that's normal lymph gland tissue. But most of the lymph gland is replaced by these well circumscribed granulomas highlighted in yellow here. So the key to understanding sarcoidosis is the nature of these granulomas. So what are these granulomas? What cells are in them, and how do they get there? Well, granulomas are composed of cells of the immune system called macrophages. We can prove that by staining up macrophages, for example, in a brown stain here on the right. And this shows that the majority of cells in that granuloma are these macrophages. So what is a macrophage and what does it do? Macrophage comes from the Greek big eater. So these are large cells that are known best for ingesting infective microbes. So they recognize, ingest, and digest infective microbes, bacteria, fungi, but they will also eat any sort of small particle. And they respond by producing a vast array of biologically active chemicals, some of which are important for forming a granuloma, as we'll see in a moment. The macrophage itself in the lungs or the lymph glands or other organs, skin, arises from circulating white blood cells called monocytes, which make up about 5% of the circulating white blood cells. And these themselves are derived from the bone marrow blood factory. So macrophages in some situations can clump together to form these granulomas, and they particularly do that if they ingest a bug that cannot be then digested. And a classic example would be TB, tuberculosis. So macrophages coming together to form these granulomas is a normal and important process in response to certain infections. And you can imagine that if there's a bug that can't be digested and killed, that actually containing it within this granuloma, as happens in TB, is an important way of containing that infection. But we heard earlier from our case presentation that in sarcoidosis, there is no infection, and yet patients with sarcoidosis form these granulomas in the tissues. And we now understand that the reason that this happens is that these macrophages, and indeed the monocytes in the blood from which they are derived, are hyperactive. They are responding in an exaggerated fashion as if there's some infection there, but there is no infection. And it's this hyper-responsiveness of these macrophages that leads to the formation of the granuloma. And there are various lines of evidence supporting that, which I don't have time to tell you about this morning, but I'll show you one well-recognized clinical example of how these cells are hyperactive and either respond to no stimuli or innocuous stimuli. And that's the presence of skin sarcoidosis in tattooed skin. So it's been well recognized for a long time that sarcoidosis in the skin has a predilection for tattooed areas where there is ink pigment in the skin. And here, those hyper-responsive macrophages are forming granulomas, which are forming little clumps shown in the white arrows here, nodules of sarcoidosis, particularly in the dark ink pigment areas of the patient's skin. So a granuloma forms when these macrophages are hyperactive, more monocytes come in, they turn into macrophages. Some of them become these giant cells illustrated in the middle here. This whole process is driven by the production of those chemical mediators, those biologically active chemicals which these cells secrete. That's illustrated here with these yellow stars. And these chemicals are responsible for generating that granuloma and maintaining that granuloma. And of course, what we want to see happen in sarcoidosis is that these chemicals diminish, they reduce, and hence the granulomas resolve. And that reduction in the chemicals called cytokines and the resolution of the granuloma may occur by itself over time, spontaneously, or may need treatment in order to speed up that process. So let's go back to our initial clinical case study of this gentleman with cough and breathlessness and fatigue, aches and pains with this abnormal X-ray and a biopsy showing granulomas. What did we do? Well, we made an active decision to adopt a period of observation. We deliberately did not give any treatment, but monitored closely. And the close monitoring is important. And 2 months later, the patient's symptoms were much better, and his chest X-ray had returned to near normal. So this is an important point, that sarcoidosis may, and in fact often, will get better by itself with time. And a period of observation is often the best option. That doesn't mean doing nothing, because close monitoring by a clinician who understands sarcoidosis is a very important part of that. But this whole process of the cytokines, the activated macrophages, and the granuloma formation will sometimes or often get better by itself. And you can imagine then that one of the consequences of that is it makes it difficult to assess treatments for sarcoidosis about whether they're working or not, because many people will get better by themselves. And I'm going to give you a quote now from a chap called Louis Siltzbach, who was an American physician who did a lot of the pioneering research into sarcoidosis in the 1950s and 1960s. And he recognized that sarcoidosis would often get better by itself. And he said, part of the difficulty stems from the unpredictability of spontaneous remissions, in other words, getting better by itself. This accounts for the many transitory successes reported at one time or another with such agents, treatments as calcium, gold, arsenic, potassium iodide, cholmugra oil, antileprol, and tuberculin. So these were a whole range of treatments that were proposed for sarcoidosis at the time, because if patients were given them, they would get better. But many people will get better by themselves. And this illustrates a very important point in clinical research, that the only way to properly test the effectiveness of a new drug for sarcoidosis is to do a proper randomized controlled trial that includes a placebo dummy group. That is the only way to tell whether a new treatment is going to work. So we've heard that sarcoidosis may well improve by itself, the whole process diminishes, but sometimes not. And we then have to decide when we should offer treatment, which tends to be in the form of steroid therapy. And it's, again, well accepted in the medical community now that the indication, the reason for treating sarcoidosis or offering treatment, considering treatment, is if it is dangerous. Now, there may be some judgment applied as to what does dangerous mean, but examples would be if there's a lot of disease, if there's disease in the wrong place, or if it's getting worse. Again, coming back to that observation and monitoring to see how the disease is behaving. So here's a different example from our initial case with the patient's initial chest X-ray on the left-hand side, and with a period of monitoring. In this patient's case, it didn't get better, it got worse, and you can probably see that the X-ray on the right shows more disease in the lungs than there was on the left. So in this situation of worsening disease, therapy with steroids may be considered. So steroid therapy works in sarcoidosis. It's usually given as the drug prednisolone, tablets by mouth. And steroid therapy works because it reduces many of those cytokines, those biologically active chemicals, which are driving and maintaining that granuloma. The granulomas shrink and resolve, and the therapy works reasonably fast within a few days or weeks. Steroid therapy is a kind of shotgun therapy in that it works on very many of these chemical mediators. And we'll come on in a moment to talk about how a more targeted approach focusing on one or two of those chemical mediators that are key might be a better approach. But when weighing up when to give treatment for sarcoidosis, if it's looking like it may be dangerous, there's a balance, of course. There is no curative treatment for sarcoidosis. The treatment that is offered, steroid therapy and similar drugs, suppresses the whole process, but doesn't make it go away. It may decide over time to resolve by itself. That would be the natural history. The treatment is suppressing things and making things get better more quickly. So we have to weigh up on one side of the balance the likely benefit that we are aiming to achieve with therapy, and weigh that against the potential downsides of treatment, because all of these treatments have their potential side effects. And for steroid therapy, that can be problematic. And some patients will tell us that the treatment can be worse than the disease. So it's a very important balance to get exactly right, and needs a proper, educated, informed discussion between patient and clinician about what are we likely to achieve, how are we going to monitor that and see that we've achieved that, and what are the potential downsides. What other ways could we treat sarcoidosis other than steroid therapy? Well, we can pick some of those critical cytokine chemical mediators that are vital for granuloma formation and block those specifically in a targeted fashion. So a classic example would be a cytokine called TNF, which is a vital cytokine. And if you block that, that does lead to improvement in sarcoidosis granulomas. TNF blocking drugs have been developed for the treatment of rheumatoid arthritis, so we can repurpose them, take them from use in rheumatoid and use them to treat sarcoidosis. Of course, these are powerful medications given by injection, and they're not without their own set of problems again. So the same principles of weighing up benefit versus risk still applies. It always applies when thinking about treating sarcoidosis. We are fortunate in that we are entering a new era of drug therapy for sarcoidosis. And on this slide, I've listed 4 clinical trials that are currently ongoing in the UK. They're all multinational, international studies, but recruiting patients in the UK to new treatments for sarcoidosis listed here. But the column on the right makes the point that, that all of these treatments are focused on the activated macrophage precursors, the monocytes that are forming these granulomas. So it's focused on granuloma biology and trying to reduce that. So I'm going to finish up with this slide with another quote from Siltzbach. 70 years ago, he said, "The etiology, the cause of sarcoidosis still eludes us, as does the definitive treatment." And we've made a bit of progress since then. But what I hope I've showed you this morning is that by focusing on what we understand about the biology of the granuloma and the cells that make it up, that gives us hope for new treatments for the future. So thank you all for listening. I'd like to thank Sarcoidosis UK and the other organizations who funded our own research, shown here at the bottom, their fundraisers, and of course the patients who participated in clinical sarcoidosis research, without whom these advancements in knowledge and understanding wouldn't be possible. Thank you very much, and back to you, Graham.
Thank you, Simon. That was absolutely fascinating. And I think it's very clear from looking at some of the comments in the chat that many of our people with us today are still very new to this disease. And I think you've been very, very helpful in what you've said to them. So thank you. And from my point of view, clearly Chul Mugra oil needs to feature in our next charity quiz, because I hadn't heard of it either. So that's a guaranteed point to me. We've got about 13 minutes now before the next session, and we have a whole host of questions to throw at you. So I'm going to go through the questions as presented to us, and some you've covered, I think, slightly in your presentation anyway, but let us pick up with these. So the first question is a very common question we get, is what are the most common symptoms, and how long typically could I have had it and not have known about it?
Good questions. So the symptoms depend on which parts of the body are affected. Lungs commonly, so cough, breathlessness, perhaps wheezing. But of course, whichever part of the body is affected, that's what's going to lead to the symptoms. And I think the best reference for that is the information that's on the Sarcoidosis UK website, Graham, because you have information on sarcoidosis and how it can affect different parts of the body. And everybody's different. And usually the way that sarcoidosis appears, if it affects certain parts of the body at the beginning, that's usually how it stays. So everybody's different in that respect. The question about how long I've had it is a good one, because quite commonly nowadays we pick up sarcoidosis by chance in people who have an X-ray or a scan for some other reason, and they've clearly got sarcoidosis in the lung or the lymph glands or somewhere else, and it's clearly been there for years or decades. And so there are a lot of people out there who have asymptomatic or minimally symptomatic sarcoidosis. They've had it for a long time and it's never caused them any trouble, and it's picked up by chance. And it's possible that people who are newly diagnosed with sarcoidosis, sometimes it may have been there for a very long time.
But the difference between chronic sarcoidosis and acute sarcoidosis?
Yes, so this relates to the time course as well. And I'll just try and share this slide as well here. So acute and chronic are medical terms that that refer to the time course of a disease. So acute is something that comes on fairly quickly over a short period of time, and chronic is something that lasts a long time. And the classic acute presentation of sarcoidosis is named after the Swedish physician Löfgren and is often referred to as Löfgren syndrome. And it seems to be particularly common in Scandinavian countries, particularly towards the North Pole, for reasons that aren't entirely clear. But we do see people with Löfgren syndrome. And the important point about the time course is if it seems to come on fairly quickly, fairly rapidly, as in Löfgren syndrome, then people usually do very well. So sarcoidosis that comes on very quickly usually settles down over a period of time by itself without any treatment, with a period of observation. Whereas sarcoidosis that's more chronic and lingering and grumbling in the background is less likely to get better by itself. Löfgren syndrome is characterized by these painful red lumps on the legs, which are given the name erythema nodosum, often misdiagnosed as infection or cellulitis. Patients often have joint pain, particularly affecting the ankles, and the chest X-ray shows enlargement of the lymph glands, like we saw in the case that I presented in the case study. Okay. So it's important to recognize that, because that is so typical of Löfgren syndrome, that combination of features, that patients probably don't need a biopsy to prove that that's sarcoidosis, and it can be monitored, and there's a 90% chance that it'll get better by itself with just some symptomatic treatment.
Right, so really is a case that time and symptom development can be the only indicator here sometimes then.
Yeah.
Yeah. Okay, when you mentioned joints just then, and one of the questioners had asked us, can I still get symptoms, lack of energy and joint pain perhaps, even when not in a sarcoidosis flare-up?
Yeah, so we've talked, haven't we, about sarcoidosis getting better by itself. But that's perhaps a slight misnomer, because it probably doesn't go away completely in that situation. It probably smolders a bit in the background. And if you were to go looking very hard, not that I'm suggesting that we should, but if you did, it would still be there, grumbling or smoldering in the background, but in balance with your body and, you know, your immune system in balance there. And that can cause some troublesome ongoing symptoms as described. Fatigue, aches and pains would be the common ones. The challenge there is what to do about that. That's a very challenging situation, because in that situation, when it's not dangerous, we would normally regard the downsides of treatment as outweighing any likely benefits there. And I think most patients that I speak to would come to that conclusion themselves. So yes is the answer.
Okay, but yeah, I mean, often we see cause and effect for diseases being mentioned, and stress is often mentioned as a cause for many symptoms beyond sarcoidosis, in fact. But is there a link specifically here?
So of course, absolutely right. Stress can exacerbate symptoms of sarcoidosis or many conditions, absolutely right. So, but can stress affect the way the immune system behaves, and hence, you know, how sarcoidosis behaves? That's entirely possible, but we really don't know that for sure. It's a difficult area to research, but it remains entirely possible. And some patients will certainly describe an association between mental stress and how their sarcoidosis is behaving.
Right, but presumably also the mental stress of sarcoidosis can also be a negative factor in the future prognosis as well, I guess.
Yeah.
Okay, the big question that often gets raised around lung disease is there a link between smoking and sarcoidosis?
Yes, I'm a bit sad that someone's asked this question, because that means I'm going to have to answer it. And the truth is that sarcoidosis is one of a very small number of diseases that is less common in smokers than in non-smokers. And that's quite well established, actually. So we are not recommending taking up smoking or application of nicotine for the treatment of sarcoidosis, but it's not more likely to occur in smokers.
Now, you talked about prednisolone and in your presentation. So a question here is coming: how can we prevent osteoporosis from taking prednisolone, since we shouldn't be taking vitamin D and calcium at the same time?
So one of the main hazards of long-term steroid therapy is osteoporosis, thinning of the bones and increased fracture risk, and we need to try and minimize that. If you're taking prednisolone long-term, then taking a drug called a bisphosphonate, like alendronic acid, which is typically taken once a week, is a good way to try to minimize steroid-induced bone loss. But being kept replete in vitamin D and calcium is important as well. And what the questioner is asking here is a point that some people with sarcoidosis, a minority, run into trouble with high calcium levels in the blood, which is made worse if you take vitamin D. So that's the issue. The reality is that high calcium levels only affect a minority of people with sarcoidosis, maybe 1 in 10. And if you're a patient with sarcoidosis who's never had a problem with high calcium, you will almost certainly be fine with vitamin D. If you're a patient with sarcoidosis who's had high calcium but are on treatment with prednisolone, you will be fine with vitamin D, because even a low dose of prednisolone is very effective at suppressing the high calcium levels you can get with sarcoidosis. So the only people I would worry about are people with sarcoidosis who previously had high calcium levels, who are not on any treatment. And there you've got to be particularly cautious with vitamin D. Now, you probably could take vitamin D, again, with close monitoring. And I think the message of close monitoring is coming out quite a few times, isn't it, already this morning? And so if you did take vitamin D in that situation, you would want to have your blood calcium checked on a fairly regular basis. And indeed, if you were to feel unwell, because the symptoms of high calcium can be very many. So I think there's probably too much concern about vitamin D in sarcoidosis. You have to be cautious, monitor the levels, and it's really only a minority of people who are at risk.
We very often, I think, focus too much on lungs and cardiac sarcoidosis, but obviously there are many other types out there. And a questioner here is asking, how do you treat it when it's on the skin?
Yes, so this is a good point, which I haven't had a chance to go into, so I shall just, but I shall take this opportunity to share another slide. A principle of treatment of sarcoidosis is if treatment is needed, but if you can treat it topically, targeted at the particular area, that is the way to do it. And skin is an area where you can put treatment onto or into the affected skin, and the eyes are another classic example where, of course, you can put steroid eye drops into the eyes. So here's a patient of mine who kindly agreed to be photographed again, and she has these rather large lumps under the skin between her thumb and her index finger, which means she can't actually oppose her thumb to her index finger, which of course is critical for function. My friendly dermatologist gave her an injection of steroid into the lesion, and a few months later it was very much better, not completely gone away, but very much improved, and she was able to regain function of her hand. So topical, local treatment, if possible. If not, then the treatment is the same as treatment of sarcoidosis anywhere else, with steroid tablets and other drugs. And again, the same discussion about weighing up benefit against downsides needs to be had.
Okay, thank you. Right, we have 2 minutes left, so I'm going to ask you an impossible last question. What could be done to avoid sarcoidosis affecting the lungs and evolving into fibrosis?
Well, fibrosis is the outcome that we don't want in sarcoidosis. So I agree with that, because that's irreversible damage. The answer again, Graham, briefly, is going to be the same as I've said before, which is close monitoring. Close monitoring, looking for any evidence of deterioration, and treating if we think that that is dangerous and risk of progressing into fibrosis or scarring would be a danger signal. Would be true to say that we do not know for sure that treating in that situation will reduce the risk of scarring, if that's going to be the natural way that it's going to behave, but we think and hope that that would be the case.